Screen. Yeah, we're good. Okay, sounds good. It's really such a pleasure to talk to you guys today about something that's really dear to me, the social determinants of health. And as my fellows would probably tell you, and they tease me all the time about the fact that I'm not going to be able to cure world hunger. And I'm not out to do that, but I think that the way that we can potentially make some difference in the world is looking at things in a systems way and figuring out solutions and working together to get to that end. I think that, I'm going to use COVID-19 as somewhat of a stepping stone to start talking about social determinants of health. And I think what it has done, what COVID-19 has done is it has allowed us to have the conversation about social determinants of health in a much more meaningful way. I think a lot of people have been in this arena and been thinking about social determinants of health, but only now has it put it in the place where it should have been in the beginning, in places of policy, in places where the public's eye is looking on upon us to make a difference and make changes that are meaningful. So with that, I'm going to just get started. So, these technical things, I hope I can do it. Okay, so the slide. Okay, here we go. There we go. So I have no financial disclosures. So today we're going to talk a little bit about, the demographics of COVID-19 and how did it impact with social determinants of health, and then just talk about social determinants of health in general and who does it affect. And then more specifically, we're going to look at the effect of social determinants of health in the intensive care unit. And what we're doing here. A lot of the people in the Department of Medicine, the residents, the fellows have really been working very hard. Medical students have been working with us on this team approach to helping with social determinants of health and then our future direction. So just to go over a little bit of the stats right now, as of October 17th, there have been more than 39.2 million confirmed cases of COVID-19 and close to 1.1 million confirmed deaths. In the United States, there have been 7.9 million confirmed cases and close to 200,000 confirmed deaths. Where are these deaths occurring? Unfortunately, they're sort of disproportionately occurring in patients of color. So Blacks and Latinos are 3 times more likely to be affected and 2 times more likely to die. If you look at this graphic, it does look as if whites are more likely to die, but this is related to age. As you know, the elderly are more likely to pass away from COVID than the younger age groups. And when you adjust for age, Blacks and Latino residents are more vulnerable for COVID-19. The interesting part is that, in New Jersey, we're very diverse, and you would think that they wouldn't really affect us. We are much more inclusive of our counterparts, our Black and Latino populations, so we think. But in actuality, that's not the case. Most of New Jersey, because of policies such as redlining, has sort of segregated our individuals of color into areas that are much more urban in nature, much more crowded. They are the ones who are the frontline workers, more likely to be exposed, less likely to be able to be isolated. And so they were the ones who were much more affected by this pandemic and more likely to die. Not only do we see this vulnerability just related to individuals who are color, but they also are based on socioeconomic status. So data coming out of New York showed that individuals who were much poorer were much more likely to have COVID-19, and individuals who were of higher poverty status were also more likely to die of COVID-19. What was happening in our ICUs and in our hospital? So a lot of this data was mined by Jay Batson as well as Tom Nahas. So a lot of this data, as you can see, it does tell us that we were more likely to have individuals of color in our hospital as well. But one of the striking facts, and why we really cannot look at these things in a meaningful way, is just the documentation. A lot of our patients who come through the hospital do not have good documentation of race or ethnicity. And so, as you can see, a lot of the patients are just written as other race. And so unless we have some of that transparency happening, we won't be able to get to the heart of the issues and the problem. But that being said, we had a lot of patients who came through our hospital. We took care of 1,048 patients with COVID-19 from March to the end of May. A lot of those patients were either other race or African American, and individuals of color were much more likely to die. In terms of insurance status, individuals who had Medicare or other insurance were much more likely to be exposed and have cases, and they were also much more likely to die. So that was the case in our ICU and in our hospital. That being said, our hospital actually did a really good job of trying to figure out where the hotspot areas were for COVID-19. There were actually 2 neighborhoods in New Brunswick where a lot of cases were coming through, and they went out to those neighborhoods and were able to isolate them, and they were actually able to get them tested. So they did a lot of work. Our caseloads and our death rates would have been much, much higher if that did not happen, if those community connections were not already in place. I just wanted to go through this history of social determinants of health, and it's not anything new that we're dealing with right now. It just seems to be at the forefront right now. But even back as early as the 2000s, the World Health Organization had really decided that it was something that needed to be addressed and combated. They defined the social determinants of health as areas that are made up of social gradients, stress, early life experiences, social exclusion. They also, in 2008, the World Health Organization aimed to close the gap. They aimed to close that gap in a generation, which has yet to happen, and they aim to understand social injustice and health equity. In 2010, the Affordable Care Act established community-based change and initiatives to try to transform communities and give them money to be able to build up communities so that, healthy communities result in healthy people. In terms of our history here, I have to say Robert Wood Johnson University Hospital, as well as the medical school, but much more clearly the medical school, has a very robust history looking at social determinants of health. So I don't know if you guys know Jeff Brenner. He was actually one of my classmates, and he won the MacArthur Foundation Award for his seminal work in this area. He developed the Camden Coalition and was the president of that for a very long time and stepped down in 2017. But he basically coined the idea of hotspotting. This idea that there are areas even in the same community that have less resources, that need help, that we as a community can go and help these individuals so they don't have as many ER visits and use as much hospital resources. From his hotspotting trials, we actually, our Department of Family Medicine also did a similar trial looking at hotspotting areas between individuals who came through St. Peter's ER as well as Robert Wood Johnson University Hospital's ER, and they were able to figure out where those hotspots were. Dr. Talia led that work, as well as Dr. Like. And currently, Dr. Like and Dr. John Maria Pellerino have been working with the New Brunswick Alliance to connect the community. So there's a lot of history in social determinants of health work that's ongoing through the medical school as well as the hospital. The medical school also has an incredible social determinants of health curriculum, and they do a really good job making sure that that's part of that curriculum and understanding. So just further to go through the World Health Organization and looking at what factors affect health outcomes. I know this slide is somewhat busy, but it does underlie the fact that we as an individual have so many things that are affecting us, right? It's not just about medical health care and what doctor we see and what kind of medications we get, but everything about our environment affects us, our behaviors that we're taught very early in life, even the friends that you have, those behaviors that we sort of mirror are very important. Social circumstances, were you ever incarcerated, all those kinds of things, what kind of schools you went to, those all affect the way that you, your health and your health outcomes. So I'll just go through the actual definition of social determinants of health. Those are the circumstances where that affects our abilities to grow, live, work, and age. Sometimes they're underscored by unfair and avoidable differences in health status. And it also is largely responsible for the health inequities driven by policies, attitudes, and social injustice. And I think that this sort of defines it the best, is quote, and unequal distribution of health damaging experiences is not in any sense a natural phenomenon. But it is a result of toxic combination of poor social policies, unfair economic arrangements, where the already well-off and healthy become even richer, and the poor, who are already more likely to be ill, become even poorer, and bad policy and bad politics. So I think, you know, that definition by the World Health Organization underscores the fact that these things are changeable. These things are factors and policies that we have to work towards changing. That was the aim in 2020. Back in like 2000, the aim was that by 2020 we would have healthy people, that our communities would be well. Obviously that has not happened, and so that has been pushed to 2030. So let's hope that we get there by then, but those are the goals, to try to build better neighborhoods, better environment, social context, all those kinds of things. Well, I think the underlying point is, will it make a difference? I mean, will making these changes, helping build communities, make a difference in health outcomes? And I think there is a lot of evidence that points to that fact. So this was done out in Houston, where they took 39 patients who had at least 10 emergency room visits or 4 hospital admissions over the previous year. And what they did was that they did this, what's called a wraparound kind of care model, where they had social assistants, they had chaperones, they made sure these patients followed up on their appointments, got the medications they needed. And what they found was that over the course of 6 months, they were able to save close to $1.3 million. So as you can see, before and after intervention, there is clearly a decline in healthcare utilization. There is a decline in cost, and then there's an improvement in patient functioning. So looking at all these factors, you know, most of the work of social determinants of health was done in the primary care setting, and it's sort of still in that setting, either in the ER or in family practice settings, primary care. But what we decided, and this actually just happened in a conversation I was having with Dr. Carol Ash when I was coming off one of my shifts. And we said, you know what, these patients that we're seeing in our ICU, they're coming back all the time. We work so hard to get them well, but why do they come back? And we said, you know what, it might be that we're just not connecting them in the right way. We're just not making sure that their follow through is happening. And that's where it all sort of began. So what we asked ourselves was, can improving the social determinants of health of our sickest patients outside of the hospital help prevent future readmissions to the ICU? And that sort of started our entire project. So the way that our project worked is that we said, you know what, it's very important to educate our providers prior to starting anything. They have to understand the importance of social determinants of health in the ICU setting. Then we wanted to see what would be the impact. What's the impact that's going on right now in our ICU? So we did a retrospective study. Then we said, well, once we do that, let's start screening all our patients and figuring out what are the determinants that are occurring in our ICU, and also educating the staff in terms of why it's important to look at those aspects. And then lastly, connecting with community resources. So we, got a list of all our stakeholders. We tried to figure out who to connect with, what's actually happening. And so this all started back in 2016, and we've been sort of trudging forward. So back then we did a half-day seminar where we taught social determinants of health in the medical intensive care unit. I remember reaching out to Dr. Wandersford to say, hey, we need some money for this. He and the hospital did a partnership where they funded this half-day program. Both sides gave 50-50 to say that, yes, we're on board and this is important. So during that half-day seminar, this was our agenda. We talked about, we invited all these providers to come through. We talked about social determinants of health, why it's important. We did a lot of critical thinking exercises. We did role playing, and we had a panel discussion. We talked about how difficult and complex the system is, how in order to have healthy people, you have to have a healthy society. We talked about all of the things that affect social determinants of health. And then we also introduced Dr. Likes' mnemonic of how to address social determinants of health practically when you're seeing patients, this mnemonic called Theseus. So you can ask your patients about the different social determinants in a meaningful way. Lastly, we had a panel discussion that included the CFO of the hospital at the time, Mary Pellerino, that represented the community, Ari Cardine, who represented social work, and Jennifer Rosen, who represented legal services, the incredible work that they're doing up in Newark to provide free legal assistance for patients, for individuals in need. What happened in terms of the outcomes of that health education initiative? Well, 98% of the individuals who took part responded to the survey. And we found that participants were more confident and prepared in recognizing social determinants of health after the conference. They also felt less inadequate in helping and directing their patients to meet their social needs. And so we used that as a jumping point for doing all our screenings and further education in the ICU setting. So this is just some of the data in graphic form. Then we moved on to the retrospective study. We wanted to get a sense of what our unit looked like. Who was coming through? Were they having social determinants? So We conducted a retrospective review of our patients over a 10-year period from 2004 to 2014. Approximately 6,531 patients were admitted to our ICU. And over that period of time, 16% of individuals were readmitted in 30 days. And then you know what that means. As it is, ICU costs are through the roof. But in addition, these individuals who are being readmitted have a much higher mortality rate. They're double the mortality rates than those patients who would not be readmitted statistically. So we also looked at, who are these patients who are coming back? And when we looked at race and by age, what we found was that every 10-year increase in age, the odds of being readmitted were increased, and also that Black patients were more likely to be readmitted than any other race. We did not find any statistically significant impact of sex or zip code on these readmissions. One interesting fact was that individuals who had charity care or no insurance were less likely to be readmitted. And I think part of that might be that at that period of time, you were having a lot of outreach, and district clinic was following up on patients to make sure that they weren't having 30-day readmissions. The retrospective study also found that the average length of stay for those patients who were readmitted was much higher. And also those individuals who were readmitted had increased direct costs. Well, where were these patients coming from? What we found was that these patients were coming from 3 different geographical areas. They were coming from North Brunswick, Somerset, and Monroe Township. This prompted us to have another study looking at the Monroe cohort, because we were interested in saying, hey, why should these individuals who are relatively well off compared to other areas in New Jersey coming back and being readmitted? That cohort study is actually in the works. Brian Jacobs and Yisha Chen, who are both medical students, worked on that IRBN survey. Unfortunately, COVID hit and we were not able to go out and do that, but that will be something that we're looking at in terms of why are these individuals coming back. So on to our prospective study. This is what we're doing currently in our ICU. We are screening for social determinants of health, but before doing so, we really did put a lot of thought and effort into screening. As you know, you can't just screen, right? It's unethical to just screen. And so we took this tenet to bear. Screening for any condition in isolation without the capacity to ensure referral and linkage to appropriate treatment is ineffective and arguably unethical. And we really took this to heart. We worked very hard to make sure that we have a structured system put together that sort of unites us, the medical school, with the hospital, with the community and community resources. And a lot of this work could not have been done without the help of Charles Wilson. He no longer with the hospital system, but he was very much a key player in this. I remember just walking down the hall one day and Charles happened to be there. I'm like, Charles, we have to do this. We definitely need to help these patients. And he's like, no problem. And he was able to link me with the IT that I needed from the hospital, all of the social workers, get me on, talking with individuals at corporate. That connection was really key to making this project work. We also made sure that we incorporated key factors in our screening. So we wanted to ensure that the patient, that family and patient-centered screening for social determinants, that it was really much more patient-centered, something that would relate to them, that we integrated the referrals and linked them. And I hope you guys will see how we did that when we go through the different ways when we're screening. We perform them in a context of a comprehensive systems approach. We use a strength-based approach to support patients and their families, and we screened everyone. We're not limiting our screening to just individuals who we think have apparent social needs. And you would be shocked. I mean, screening through the ICU has really been a humbling experience. It seems as if like the elephant in the room has finally been appreciated. And when I walk into the room and I'm like, I need to talk to you about this idea, I can feel that I've taken off a weight on their shoulders. There have been families who've come out after I've screened and said, thank you so much. Nobody's asked me these questions before. There was actually a physician who was in the ICU, and the wife came out to me and said, you have no idea how close we are to losing our house. And, you know, just any kind of help would be so appreciated. So we do not, you know, say we will only screen this individual because I think they have determinants and this other individual will not, because we know for a fact that's not the truth. Every one of us probably has some determinants that we need to have addressed. So these are the questions that we're screening. There are about 8 questions that we're asking. As you can imagine, in an ICU setting, it's sometimes hard to, you know, make these screening tools that are 20 questions long. Nobody, one, has the time to do it. 2, no patient is going to give you that kind of attention. These screenings in the beginning, Natalia Levitska is one of the fellows, and Bandhan and I would go around, and when we got a chance, we would screen in between our workload. But currently, we actually have a part-time social worker who, through the district clinic and Andrew Thomas, has been sort of given to us, and she's been screening, and it's really been much more helpful. And Dipali's group, the pharmacists, have also helped in the past in terms of screening. These screening questions have come from a validated screening tool that the family practice group has used in the past throughout the nation. It's called One People, and that's these are the screening questions that they also use when they are screening for social determinants of health. So it really just talks about, you know, housing, food insecurity, utilities, medications, health literacy, all those kinds of things. At the end of the questionnaire, it asks, would you like to be linked to resources? So the way that this works, and it's in our EMR, if you guys just type in social under documents, it will drop down. It will have a drop down that will then allow you to enter these values, yes or no. It'll also ask you for, you know, education level, the name and the MRNs and all that are self-populated. At the end of the screen, it'll have a click button that says, would you like to be connected with resources? And with that click, it will generate a social work consult. These forms also generate a district consult. So the social workers will also connect them to district clinic. When these patients go to social work, they then will get a referral. So if you look at the bottom of this form, it'll say, hey, so in the last 12 months, did you ever eat less than you felt you should because there wasn't enough food or money? If they had said yes to that, the social worker will then refer them to one of those places or type in. So let's say where do we find these places, right? So these resources are our community resources that our social workers normally send our patients to. And we populated these forms with that, so then we can know where they're being referred, because the solution is not screening, right? The solution is making sure that you're connecting them, and not only are you connecting them, that you're following up on them, right? So these forms are all in the EMR. Took us a very long time to get them all in EMR, and I have to say, Karen Alcorn and Asai, they were just incredible in helping us, and Brenda Lawrence in trying to help us to make sure that this is all in our EMR. And remember, with social determinants of health, when you are screening, you can generate Z codes, and so there is billing generated with these patients. So what have we been seeing when we've been screening these patients? So far we've screened close to 248 patients. Of those, 174 are males and 74 are females. This is the race and ethnicity distribution that you can see in our patient cohort. And then this is the breakdown in terms of the determinants. So 20% of individuals found that getting access to medication was difficult, and 20% found that paying for their utility bills was difficult. And what's interesting is that, you know, we'd been screening prior to COVID, and then we've continued after COVID. And what we found was that after COVID, there's been a lot of increase in caregiver kind of determinants. So individuals are having a hard time either providing care to their elderly loved ones, or the elderly are having a hard time giving care, like they have children who they cannot take care of because they're not well. All those kinds of things are much more common now post-COVID. But this is the breakdown so far in our unit. And as you probably all know, patients who have one determinant usually have more than one determinant. And that's something that we also found in our ICU, that patients who have more than one determinant usually. So where are these determinants? Where are these individuals? Which zip code areas? So individuals who have issues with housing and housing insecurities are sort of geographically more located in Somerset and in Monroe and South Brunswick. You know, these are just preliminary data. So in terms of teasing out why that is, those would be the next steps. But you know, what the zip code allows us to do is, and we'll go into how we're making these connections. These zip codes really help us decide what resources are available for them. And then these are individuals who are have difficulty with access to medications. So they're more likely to be in Piscataway and Edison, and again, Monroe and South Brunswick. And then in terms of utilities, issues in Somerset and in South Brunswick. And then caregiver needs are much more common in Piscataway, Edison, and Monroe, in those areas. So in terms of our prospective study in readmission rates, so individuals who had social determinants, those individuals were much more likely to be readmitted, 10% more likely to be readmitted versus those individuals who did not have determinants. I do get every week I get a snapshot sent to my email in terms of who was screened, what were the determinants, where were they referred, and also I get an alert if they were readmitted. So, you know, I think the most important thing is making sure these connections happen. So we do have a follow-up survey that we're conducting. Patients are coming through to district clinic, and then we're following up with them to see, hey, did you connect? What was the experience like? Was your social determinant taken care of? What we found is that these connections are just not happening. And that despite the fact that we're doing all this work, despite the fact that we're finding the resource for them, it's not happening as well as you would think or want to happen. And so we're working very hard to try to make sure that those connections happen. And so the way that we're trying to connect with community, this is sort of like our process map that we're trying to do. So as you know, right now, we are screening for social determinants of health for every individual that comes through to the ICU. We're referring them to social work. They are then trying to make the connection with the community, these resources. I will go into, right now, we're manually doing it, but we were actually picked as a pilot program for NowPow. Our healthcare system is instituting a NowPow program. IT fix to help with community resource referral. And then we are also working very hard with an engagement platform that I will go over. That is also considered an IT fix to try to engage these patients in a much more meaningful manner. And we're working with the hospital system as well as district clinic to potentially hire what we would call nurse navigators, or individuals who would help to make sure that these connections are happening, that they can make sure that they're addressing barriers to that connection. So this is NowPow. NowPow is a platform where you basically figure out what the need is of that individual. That need will then generate resources that are available. Those resources then can be tailored based on your zip code. Okay, so what I do is, let's say it's me that I go in and I screen positive for, I don't know, and issues with housing. I will then get an entire list of resources that are available in my zip code. And then I will be then referred to one of those centers. The NowPow app will then nudge me and remind me to go. What we are also making sure happens is, and we're working with NowPow for this to happen, is that when I go to that community resource, whatever kind of communication I've had with those workers at that community resource, my physician will be able to see what happened. They will get that progress note. They will know what the next steps I will have to take. And so that kind of closed loop is what we're working to make sure happens. The other platform that that we are also engaged in, and it's something that the healthcare system has basically contracted with, is Consejo Sana. Consejo Sana is a engagement platform. What it does is, it's much more sort of, the way I look at it is very broad. What it does is it tells you that, hey, you know what? This percentage of patients have been coming back to you and they've been seeing you, but these patients have not been coming back to you. This is how we can potentially engage them. What's their behavior like? All those kinds of things, figuring out solutions. So it's a much broad kind of catchment, just giving data to the healthcare system that these patients are not engaged, and how can we engage these communities. And lastly, what we have actually reached out to and who we've partnered with in terms of our group is Gomo Health. So Gomo Health is much more a behavioral platform. So as you know, your behaviors are basically determined by a lot of things, right? They're determined by your past experiences. They're determined by the person who's sitting next to you telling you, like, hey, what are you doing? Why would you go see your doctor today? Why don't we like go out and do something else? Or, you know, why don't you drink that soda? I don't understand why you want to be drinking water today. So there's a lot of things that impact you. And so I think that, you know, behavior is a major reason why despite the fact that we're doing all these things, we're finding the resource for them, we're sending them there, and yet those fixes are not happening, is related to behavior. And what we're trying to do with engaging or working with Gomo Health is figuring out those behaviors, trying to figure out what works for people. Like, I'm the last person, like, if you tell me to do something, I'm less likely to do it. Whereas, you know, it's like my dad would constantly be like, yeah, I know when you say yeah, that means you're not doing. I'm like, yeah, that's exactly what that means. So it's trying to figure out those things in our patients, right? Trying to figure out what makes them tick. And this, I think they're in the right place. So we are actually launching a study with them to figure out how can I get these patients who in the ICU, we work so hard to get through this, let them finish that last mile, have them connect back with us. And so we're working on that with them. So just, you know, I want to finish up and then give you guys a little bit of time to ask me questions. But I just want a couple of takeaway points. And, you know, what I try to tell the fellows and more the residents that I work with in the ICU is that the ICU is really like being in a forest. You know, there's so many things being thrown at you. There's so much to have to sort of wade through. And that's similar to this work in social determinants of health, right? Because as you remember in that first graphic where you're this one individual with all of these things coming at you, but the way that you have to see through, the way that you see through the ICU is similar to the way that you have to see through social determinants of health. You have to find a path. You have to just sort of see that path and don't let all of the confounders distract you. Find your end game. Know that your end game is that you need to get that patient extubated and out of the ICU. Similarly, for social determinants of health, you have to sort of find that path for that patient so that at the end of the day, they are healthier and better equipped to deal with what life is going to be coming in front of them, right? So don't let things distract you. Keep focused, and realize that there's so much involved in somebody's health that's sort of out of our realm, but we have to work at this. We are leaders. We will help to shape policy. That's our job. And that's when you pick this profession, you pick that job to be that leader, to be that voice. And that 80% of health outcomes are due to social determinants of health. They're not due to that, you know, finding that medication. It's not going to do it, right? We have to address these issues. And I think that, you know, COVID-19, for whatever it's worth, gave us this time-lapse view. It sort of shrunk time for us and made us realize how important social determinants of health is, and that how to work towards building capacity so that we can address these health outcomes. And I think the ICU is an incredible place to try to do this in. I mean, working with patients who are the sickest of the sickest and trying to address those needs are really important. What this work has actually showed me too is that all of us really want the same end goal. The same end goal is to have a good, healthy patient and a good, healthy community. And everyone that I've run across has that same kind of aim. So this area, it's an incredible area to work in. And I just wanted to sort of thank my team. We have an incredible group of people that I work with. And they're from everywhere, from the medical students to the residents to people in the hospital leadership. Miriam is incredible as a community leader. And we have Vanessa, who's our health equity officer, who keeps us like, ethics and thinking in those manners. It's just incredible to work with all these people, and Andrew. So I'll just take some questions in the time remaining, if you guys have any.
So thank you, Sabiha, for enlightening us, for letting us know the work that you're doing, certainly in the ICU, and hopefully it can spread its wings into the general hospital scenario. I have two questions, and I'll pick up questions from the chat. Do we have any models in other parts of the world where the countries are more homogenous? So perhaps Sweden and Denmark or Finland or Singapore or Taiwan, where they have been able to attack this better? Do we have data on their health outcomes?
I mean, I don't have the data offhand on me to answer that question. But I do know for a fact that, you know, they do have better health outcomes than our country. But in terms of why that is it because it's more of a health system that covers healthcare for everyone? Is it based on that? I suspect it's, you know, more policy issue. I mean, none of us want to not let someone of color live in our neighborhood, right? But yet, the way that our policies are made of redlining has made us do that. It's not because we want to, it's our policies that are doing it, right? I mean, the fact that if, even in my neighborhood in West Windsor, the amount of fighting to allow a low-income community into that space, because the thinking is that our school systems are going to get worse, it's just, you know, eye-opening, right? When will that change? I think that some of that is driven by the fact that, oh, you know, our property values are going to go down, and if our property values go down, then nobody of any caliber is going to want to come live here. It's like nonsense, right? So I think that some of it is policy driven, that sort of forces us to that. But yeah, I don't know the actual data for that, but they definitely have better outcomes than us.
A second question, then I'm going to move into the chat, is that, you know, the Barnabas Health System has been advertising and probably delivering a lot of information about addressing the social determinants of health. I see it all over LinkedIn. I see it on Twitter. They've appointed leadership in this space. Can you comment on what exactly is happening as it affects this institution? Because I'm not aware of
Yeah, sure, absolutely. So Deanna minus Vincent, is right here. She's actually one of the leaders in that space. So she reached out to us very early in terms of engaging us to be part of the development of that social determinants of health platform for the healthcare system. So I was part of developing the universal screen that's going to be coming across the healthcare system. That screen and tool, they are going to somewhat tailor to us for the ICU. And, you know, they're working off of a $2 million Walmart grant that they got for disseminating social determinants of health across this healthcare system. So it's actually been really nice working with them. We're also launching an educational platform that's going to educate all of the providers across the healthcare system about social determinants of health, and will also allow people to get a certificate program for social determinants of health. I'm working with Dr. Boyan, who's here, Sumitra out of the Blaustein School, to develop that and make some policy changes. So they have engaged us. I know that they've engaged the School of Social Work as well, individuals, you know, across the healthcare system, Camden, and other Rutgers faculty to help with this program. So I think they are trying to do it in a meaningful manner. What is going to happen, like when EPIC comes through, I don't know. We are one of the pilot sites. Initially, it was going to be, Somerset and stuff, but since they saw that our program has been robust and actually has moved more forward than any other program, that's how we have access to now POW and Consejo Sana. So yeah, I think that we're in a right place to work with them and make a difference in the healthcare system. Because you're right. I mean, most of these things are happening up in the north, but I've been telling them that, we're doing a lot of work down here, and that a lot of this stuff has to start down here.
Great, thanks. I see a question here from Laura asks, are there social determinants of health intervention studies which are randomized rather than pre and post like the one you showed? Therefore, that would allow us to have more robust evidence regarding the efficacy of these interventions.
Yeah, I mean, I think that, we want to get there. The problem is that, a lot of people think that it's unethical not to give, like, if you know that there's a resource available, not to give them that resource would be difficult. The studies that we are trying to do is like usual care versus giving them, like connecting them with now POW and engaging them with Gomo. Like that's the study we're going to be doing to see if it makes a difference. Like because we know usual care, like nobody's really being engaged, right? So will that make a difference? Because you're right. I mean, the one that was done in Houston, like who can replicate that? Who has the bandwidth to have nurse navigators and people who go out and make sure that you're going to and be their chaperones, and who does that, right? So I think that you're right. It has to be done in a more meaningful, real life kind of manner.
I see some comments here that everybody could reach out to. There's a book on the American Healthcare Paradox by Bradley and Taylor that talks a lot about social infrastructure and emphasizes prevention rather than catching up with illness. And a lot of messages thanking you, Sabiha, for your insights and the trailblazing work related to social determinants of health right here in New Brunswick. So I want to thank everybody for joining and Sabiha for speaking to us today. Thank you and have a wonderful week. See everybody back next week, Wednesday. Thank you.
Thank you, guys.